The opinions expressed by the host and guests in this show are not necessarily the views of Children's Health Defense.
Well, good morning, CHD TV. It must be Friday. Let's see. It's Friday, September 26th. I am your host for Doctors and Scientists, Dr. Brian Hooker. And we have today a special guest straight from Atlanta, maybe not straight from Atlanta, recently at the ACIP meeting. That's the Advisory Committee for Immunization Practices from Atlanta. Dr. Retsef Levi. Dr. Levi, welcome to the show, and thank you so much for what you're doing at ACIP.
Thanks, Brian. I'm currently back to Cambridge to the maybe the only month of the year when Boston has good weather.
Right.
It's a pleasure to be here, and thanks for the opportunity to have a conversation. I'm looking forward to it. So.
I'm so excited to have you on the show. You know, we met earlier. We were talking about autism data science and talking about the Autism Data Science Initiative. But I want to talk a little bit, to start about your background. You're an analyst in operations management in the MIT Sloan School of Management. So given that and given your background, how do you find yourself on the advisory committee for immunization practices? I mean, I think this is fascinating. I follow your work. I think you're super talented, but connect those dots for us.
Yeah. So first, I'm not sure I can answer why I'm on the ACIP as a member of ACIP. That you have to ask who the people that appointed me or asked me to be a member
I know where he lives. He's on my phone. So yeah. Yes.
So, but I maybe I can speak a little bit to my background and try to explain why I believe that maybe people with my background can bring some perspectives that are important to thinking about vaccination policies and particularly risk-benefit analysis. So my career path is maybe kind of non-traditional. I was born in Israel, and to be honest, was in the military in a long career of almost 12 years, and never, to be honest, never thought I would be an academic. I was in intelligence and did work in the area of special operations, where from very early age, after I turned 18, I was thinking very extensively about risk and how to think about risk, how to think about uncertainties. Not in the context of a formal academic environment, but more as a practitioner. And then I finished my bachelor degree in mathematics with a trend in operations research in Tel Aviv University when I was 31, which is quite an old age to finish a bachelor degree, especially for people in the US, for which if you didn't finish your bachelor degree by 22, by 23, it seems the end of the world. And somehow I thought at that point, 31, I was offered a promotion in the military to become a lieutenant colonel, but I decided that it's time to make a change, and I took my family. At the time I had two kids, and we came to the US to Cornell University to do a PhD in operations research. And operations research is a discipline of applied mathematics that is really focused on how to use data and models to help supporting decisions that involve risk-benefit analysis and really thinking about complex systems that operate under a lot of uncertainty and how to make optimal decisions within those kind of environments. And this is a discipline that has been applied to a broad range of application domains. It emerged in actually World War II and was first used to optimize trains going into the front lines. But since then, it has expanded to be applied in medicine, in issues related to risk management and safety, to optimize cancer radiation treatments, pricing, inventory management, optimizing networks, and so forth. And my work as someone that did the PhD, after I did the PhD, I somehow ended up at MIT as a faculty. But my work over the years uh, has been focused to a large part of it has been focused on human health, different aspects related to human health. Been working for almost 19 years since 2006 when I arrived to MIT as a faculty member. I've been working with large healthcare systems in the US. So I have by now probably thousands of hours of working with clinical teams, looking extensively on healthcare data and trying to understand what does it tell us about the clinical and the operations of these systems, and also how we can use and leverage that data to optimize those processes. I've been working on issues related to manufacturing of biologic drugs, developing post-marketing safety models for drugs, um, uh, thinking about issues related to epidemiological models, but also thinking about human health from the perspective of healthy food, access to healthy food, food safety, and more recently also issues related to water management, water system management. So as you can see, I'm kind of quite experienced in looking on different angles of human health through the lens of data and how data can be used through modeling to inform decisions within complex systems that really have to balance different risks and different benefits and different options of a course of actions. Um, eh, During when the pandemic started, I've been started. My research also shifted, like many others, to do also research related to the pandemic management, and I've been involved in thinking about how to manage safety of nursing homes and protect the vulnerable patients of nursing homes. Uh, Thought about or talked about and did some research about the damage of the lockdowns and the overall health harm that they caused. And then once the vaccines were launched, I also did some research related to their safety, to their efficacy. Um, and at some point, I was asked to be part of the ACIP group, and it's a great honor and a great responsibility. I do that with a great sense of humility and responsibility. And I believe that when you want to think about vaccination policies, you really need to bring together and integrate many perspectives. And many of these perspectives um, have to do with how do you think about risk, but also how do you think about the different perspectives of a medical provider, the manufacturing aspects, the different risks and benefits that these products may have to different subpopulations. And all of these issues are very much up the alley of the discipline of operations research, and more specifically to my own personal experience. So I feel that I feel that I can be a constructive contributor to these discussions.
I really appreciate that. And I've seen you in action in the ACIP meeting. And one of the things that's a hallmark, I think, of you and a lot of the members of the advisory committee right now is the level of inquisitiveness and inquiry. There are a lot of questions that are being asked that I think are kind of a new domain. I mean, if you look at and you can take this question however way you want to, but if you look at sort of the state of where medical science was, and then you look at sort of the new level of inquiry and your training in operations management, how do you, and looking at, you're talking about different facets of risks and benefits and doing the proper analysis. How do you think that's changing, especially sort of with this new era, with the new members of ACIP and Under Secretary Kennedy?
Yeah, so I think that there are many technical aspects that you can sort of discuss, but I want to actually focus on some principles. And I think that one principle that I think that we have very strongly in essentially any other area of medicine, but somehow when it comes to vaccines, we forget about this, is the notion of personalization. That basically different patients may have different baseline health status and different preferences, and they might end up making different choices informed by their consulting physician. And I think that thinking about this core interaction between the patient and the doctor or the medical provider, right, as the core interaction of healthcare, and really thinking about the role of ACIP as not necessarily prescribing to people, uniform recommendations for everybody, but rather than providing nuanced recommendations, and more importantly, the appropriate representation of what do we know and what we don't know. To me, it's kind of the core role of ACIP. Our job is to provide to patients and their medical providers the reliable information about what we know and what we don't know, so they can actually conduct together the individual risk benefits for that particular patient, and also take into account the patient preferences, so they can make the best decision for the patient. So we really emphasize an individualized and personalized approach that I don't think we have seen in the past. And in many ways, there might be some contradictory narratives between how do you think about the individual care or health management of a patient versus the traditional approach of public health, especially when it comes to vaccines that maybe does not prioritize this as much as needed. So that's, to me, one fundamental difference. The second fundamental difference has to do with what I would call, in my broad term to this, is culture of safety. I think that culture of safety has to do with what questions are you asking and what is your mindset when you think about safety issues. My impression is that more often than not, we have adopted over the years, especially in the context of vaccines, the narrative that unless you positively show that there is a problem, safety problem, then things are okay. And to me, that's someone that actually have been thinking about safety in many different contexts and industries. That's, to me, similar to you're about to take off with a plane full of passengers, and you suddenly see a blinking bulb, and you're now telling yourself, "Oh, well, I'm not sure that there is a problem with the plane. Let's just take off." I mean, clearly, that's not going to happen, right? Clearly, the safety paradigm, the safety culture of airlines is that you are absolutely not going to take off before you make positively or reasonably positively sure that this blinking bulb does not represent a safety issue. And the reason why I believe that this is the right narrative we should adopt when we think about providing or recommending or making some assessments about vaccines is that, unlike most other drugs that are being given to people that are already sick, so for example, let's just take the most extreme situation. Let's say that I consider the risk benefits of a drug that should be given to a terminal cancer patients.
Right.
Clearly, my approach here is going to be fundamentally different, because the alternative of not giving the drug to the patient might be that they will die with certainty. So I might be willing to take far many more risks when I think about this situation. But vaccines, we most of the time, not all the time, but most of the time, we are giving them to healthy people. And moreover, we are giving them to children, to babies. So to me, the onus of proof is to show that these products are safe, and be absolutely honest about the uncertainties that we have. In other words, it's not just about the known risk, the known harm that you already established on a given vaccine, but it's also about all the uncertainties of the things that might actually cause harm, and you're not sure anymore. You're not sure yet about whether they are going to cause harm or not. And this is, again, not necessarily to say that a vaccine should not be taken, because again, it's very much nuanced, and it's very much depending on the risk benefits of the individual. But absolutely, we have to communicate those risks and uncertainties with this mindset, and not take the alternative, or maybe the traditional approach of okay, if you didn't show me that this is positively causing harm, I'm essentially going to ignore that. And I think that these 2 points are going to be fundamental points. At least I personally am going to hopefully help being part of the way we are going to discuss things at ACIP. And I suspect, but I don't want to speak in the name of everybody, but I suspect that many of my colleagues on ACIP have the same mindset in that respect.
Well, I so appreciate that. It seems like a culture of safety would err on the side of caution and would give all the information that's appropriate. And, unfortunately, you look at the vaccine information sheets that are being distributed, at your local pediatrician's office. If you look at the vaccine schedule itself, for having, upwards to over 72 individual vaccines between the ages of 0 and 18, it's rather simple. I mean, things seem rather simplistic. Do you think that, given that this is nuanced, and given that this is a personalized approach, and I love it. I mean, this checks so many boxes. And I have to admit, my son is vaccine injured. I live a different life, and I live a different lifestyle because of vaccine injury. That is my perspective. But when I hear more personalized care and personalized medicine, to me, that seems like that would be much, much more appealing to the consumer than just the onus of infectious disease.
Yeah, so Brian, you mentioned a few things, and I want maybe to relate to them. So first of all, you mentioned the vaccine information statement. In my mind, the most important vote we had on Friday was about the recommendation to basically update the information on the vaccine information statement of the COVID vaccines to include multiple risks and uncertainties that we outlined.
Right.
Because I actually think that there should be quite a consensus that the current informed consent process around immunization products is, let's say, gently, is not optimal, and some would say completely broken. And by the way, I'm relying here on a recent paper that I actually talked about it during the meeting, that is it was authored by some of the most pro-vaccine people in the country. So I think that we could have a consensus around that informed consent is absolutely important, and it should include the relevant information for the patient. So to me, the most important decision, personally, for me, the most important decision, or the most important recommendation, because we only give recommendation, is about the vaccine information statement. And I hope that that's going to be, again, something that will be disseminated more broadly than one vaccine, because I think that that's kind of one of the core principles of medicine, of ethical medicine, but also absolutely a success factor to a critical success factor to build trust in vaccination programs.
Yes.
You also mentioned, Brian, and it's always, I mean, I have 6 children, and just the thought that one of them will be with some compromised health is heartbreaking. So I don't want even to pretend that I know how does it feel to be a parent to a child that was harmed. but I think that the second important, most important thing that happened on Friday, that this was the first time when there was a formal acknowledgement of vaccine injuries and, most importantly, vaccine injured individuals. I think that, and I want to say something about that because I feel very strongly that the only way you will have a chance to have trusted and successful vaccination programs in which you basically tell people, hey, trust us, go vaccinate, take the risk, sometimes for the benefit of society, take an individual risk. And we assume almost by design that some will be injured, even even for vaccines that are relatively safe. There is
Right.
always going to be injured people, and I think if you are not going to uh, fulfill the promise that you're going to take care of the vaccine injured, that you're going to acknowledge them, that you're going to study their injuries, that you're going to diagnose them, that you're going to care for them, then you are undermining the very fundamental foundation of a trusted vaccine program. And unfortunately, when it comes to vaccines in general, but particularly the COVID vaccines, uh, these vaccine injured people were not only ignored, they were gaslighted. They were called vaccine anti-vaxxers, which is kind of it's just absurd, right? Like people that went and vaccinate themselves are called vaccine anti-vaxxers. This is just like, this is actually evil. And I think that one of the moral failures that we had around this is that we have, for a longest time, we have ignored them, we have left them untreated and abandoned. And if you follow the presentation that I gave before the votes, I think we made a very clear commitment that the COVID immunization work group is going to continue to work on developing recommendations around national program that will allow us to better diagnose these injured people, to have the right diagnostic measures, and to also invest in developing treatments. Because it's fair to say that the COVID infections and the COVID-19 vaccines created some new conditions, some new medical conditions that we have not seen before, both
Right.
long COVID, the serious cases of long COVID, as well as the post-vaccine syndrome, what is called the prolonged kind of injuries. Uh, they are new medical conditions, and we need to treat them like that, and we need to invest. We have to invest if we want to be if we want to have trust in the future. We will have to invest in addressing this major problem that is touching thousands of people.
Well, I'm so thankful for that. And again, vaccine injury, it affects multiple people. It's not, these aren't necessarily isolated cases. And one of the things that I wanted to ask you about was the current VAERS database. Right now, VAERS is the vaccine adverse events reporting system. It's similar to FAERS, which is FAERS is more for drugs rather than vaccines, drugs, and biologics, I believe. How do we right now? VAERS is so under ascertained, and I remember going to my son's practitioner when he had his vaccine injury, and she simply refused to submit a VAERS report for him. So my mom, who is a former public health nurse, took it on herself to do a VAERS report. And that VAERS report and that follow-up, I mean, even by a schooled practitioner, the report and the follow-ups could have been at least by somebody that was really good at doing these reports, would have at least taken 90 minutes. So, that's 90 minutes out of a practitioner's day. If they have like one vaccine adverse event or potential adverse event per day, how do we overcome that?
So this is a great point, and let me address. I think our safety surveillance systems currently are lacking on multiple levels. You just touched one of them, is that we currently don't have easy ways to report on adverse events. I think it's kind of mind-boggling that in the 21st century, when we have all of these advanced digital technologies, AI technologies, we are relying still on something that is relatively archaic. And I think we should think about um, um, being able to collect and solicit reports in a much more seamless way. So, for example, the vSafe concept was maybe a step in that direction, right? But unfortunately, it wasn't leveraged, and it was still lacking because it actually allowed very kind of limited text, right? But now think about the next generation of what vSafe can be, right? That basically when you launch a new vaccine, you can actually have large scale prospective monitoring,
Right.
where people can have a very seamless way to actually enroll and be asked in a more proactive way, okay, what's going on? Like, so I think we have currently the technology to fundamentally change that and have a far more robust and proactive data collection system. The other things that are broken, or at least a few other things that are broken, that our current systems, if you look on the VSD and
Right.
other systems that currently are being used by the FDA and the CDC, are entirely dependent on diagnosis codes, or almost depend, or EMR data, depending on which
Right.
system we're talking about. And as someone that actually worked in healthcare environments, I think that more often than not, we ignore the fact, or do not think through how that data are created. So diagnosis codes and EMR data is the output of very complex processes that are far from being perfect. And they're even less perfect when patients present non-specific symptoms, or kind of broad symptoms, which is very much the case when we think about the COVID vaccine, some of the COVID vaccine injuries. Uh, we need to understand that these systems are important, but we cannot just rely on those kind of systems, and we need to acknowledge the fact that we can actually miss things that do not fall to specific diagnosis, or when their symptoms seems to be, for example, very similar to transient symptoms that you're going to have after vaccination, but maybe prolonged for a year or for years, right? So yeah, you can have numbness. Well, if you have the numbness for 2 days, that's okay. That's like known, or pain. You have the pain for 2 days. Well, that can happen after vaccination. That could be part of the standard expectation that we have for side effects after vaccination. But if it prolongs for a year, right, that's a problem. And here comes another fundamental flaw in our current safety surveillance system, which is we do not have the notion of long-term safety. If you actually look on all the safety models that we currently have, they look on 21 days, 42 days at best, sometimes just a week post-vaccination. And I find it kind of a very, very puzzling conundrum in the following sense. Like, the whole point of vaccination is that it's supposed to leave a positive and lasting long-term impact on your immune system. Right? That's kind of what most vaccines, you take them once in your life, and you're supposed to be protected for the rest of your life, right? So by design, they are supposed to have longitude positive impact on you, right? So why are we thinking that when it comes to the potential adversarial impact, right, the adverse impact, why do we think that it's going to end up and going to be capped by 21 days, by 42 days, and so forth? So combining all of these flows together, that to me, and again, goes back to what kind of safety culture do we have? Because I think it has to do with some underlying assumptions that we have about the world, and whether those assumptions are realistic, and whether those assumptions really capture what I call, again, a culture of safety. And the last thing I want to say about this, that The other thing that is very, very missing to me is the lack of pursuit of understanding biological mechanisms.
Right.
And again, I'm going to think about this as someone that thinks about systematic risk. So if you think about our body as a very complex system, right? I think we all agree on that. And you now put some levers, interventions into that system. You stimulate it, like you give it a vaccine, you give it a drug, you expose it to some other environmental stimulus, right? What you see from that system, the signal that you get from that systems depend on what you measure, right? If the only thing that you measure are visible symptoms that you can measure with current diagnostic, with current traditional healthcare, right? It's going to be very limited. So when you actually do an intervention like that, you have to consider the fact that the data that you see is a function of what you measure. And I think that more often than not, we are not measuring enough, and we don't do proactive measurements of the, blood test, biomarkers, and like that. By now we know that there are some established biomarkers and other vitals that we can measure that will tell us more about the immune response of the person, some other biological processes mechanisms that happen as a result of the intervention. And we don't do that. And I think that we are trying to essentially, a lot of the time, address potential safety signals by basically doing something artificial without that understanding. And I'm going to give example from the discussion that we have had on Thursday last week about the MMRV, where basically it turns out that, when you use this MMRV as the first dose, that in the weeks following that dose, there was an increased incidence of febrile seizures, right? Which is the seizures that you get because you have fever. And the underlying assumption was that, okay, first of all, this is a short-lived kind of side effect with no longitude kind of impact. We just had the discussion about Tylenol, and we see that some assumptions about short-term impact are actually not true ultimately. But my point was the decision to say, okay, so let's just give it on from the second dose onward. To me, one of the issues that we're missing, and again, I'm talking about my personal view here, one of the issues that we're missing is that looked to me like a solution that essentially ignores the fact that you don't know what caused the first adverse events that you saw before. What is the biological mechanism that caused it? And why do you think that the solution that you propose is going to address that mechanism? And really kind of acknowledge the fact that potentially we have very limited insight into what that mechanism is. And we have to consider that when we actually think about risk. And I think that the different people come at it from different perspectives. But in my mind, when I see something that doesn't go as expected, and I also don't understand why, then I'm very, very concerned. Because one of the major safety principles when you actually think about safety in complex systems is when the system doesn't operate according to expected, and you don't even know why, that should leave you very, very concerned about the safety of that system.
This is pure gold, and your level of inquisitiveness regarding this, and from a systems approach, looking at the body, looking at physiology as a system, and asking these questions. I think fundamentally, not only do they protect the public regarding existing vaccines, but they pave the way in terms of creating new technologies that can be safer. I mean, imagine that. I can't thank you enough.
You just mentioned that, like,
yes,
I told people recently, like, we drive cars for more than 100 years.
Right.
Now, I think, but we all expect that the car manufacturers will continue to create safer and safer cars. For some reason, we created an industry that doesn't have this incentive, and I don't think that that's something that is good for anyone. I mean, and again, I'm talking about someone again that thinks that vaccines and some vaccines are very important for at least for some people. I don't believe in the religion of every vaccine should be given to everybody, or the religion that no vaccine should be given to nobody. I think that the science says that, like any medical intervention, you need to use it when it's appropriate. but fundamentally, you need to continue to pursue creating safer and safer products, and you need to create an incentive system that will drive the industry towards that direction.
Well, Dr. Levi, thank you so much. Thank you for your background, and thank you for, serving the children and the adults of the country and helping to keep us safe. I can't thank you enough for that.
So thank you for the opportunity. And I have to tell you, I bring to these meetings my hat as a scientist, but also my hat as a father of 6 children. And I do that with the utmost humility and responsibility, that these are really, really decisions that can affect the health of the most precious thing in society, which is the children and the young. So I really kind of try to put my best into it, and I hope to make at least some contributions.
Well, thank you again. I can't ask for more than that. And thank you, everybody, for joining us for this important episode of Doctors and Scientists. Dr. Retsef Levi, professor in the Sloan Management School at Massachusetts Institute of Technology, right here on Doctors and Scientists. Thank you, everybody. Have a wonderful Friday. Spread the word about Dr. Levi's interview on this show today. Thank you so much.
So we have a very special guest here with us now. A little nervous because what she's going to say, I think, is, important. So tell us your name first.
Zoe.
Okay, Zoe. And what do you do?
I'm a medical coder.
And what does that mean?
I call it the central intelligence of the hospital, or the SimCity level view. What it is you look at medical records, every kind of medical record, all the diagnostics, and you take that information and you put it into a code, which goes to insurance, and that's how hospitals and physicians get paid. So if I do my job right, then the physician and the hospital make the most money, and they don't get sued for fraud.
Okay, we have to start with what on earth went on with the hospital COVID protocols, because we've had more stories of that than anything else as we travel around. So what were you seeing?
I noticed there was hardly any patients when they called the emergency pandemic, and there was 2 weeks to flatten the curve. We didn't have patients in the hospital at that time. They slowly started to trickle in, maybe after months and months of that. We were told to basically create beds for hospitals with the executive orders, which meant we sent patients home before they were actually ready to go home, which we had never done before, because that's a financial liability. We could actually, if patients come back, we would have to pay for their care. It's a Medicare rule. So that was definitely very different. There was some financial stuff that happened, because in April, they had a code update, which they'd never done before. They had to come up with a way to track COVID. So it was all about tracking the disease, tracking COVID. And the code system is supposed to be the main tracking system. So no one had any standardized practice. Even our hospital said there's no standardized case number. So we can't even tell what's going on, even though there had already been declared an emergency, and you could see the HHS and the WHO and all of those case maps that showed us all the outbreaks. Well, it definitely didn't match up with what we were seeing in the hospital, and even the admin admitted that. So they created their own map. So that was sort of why the COVID diagnosis came out. But that's when the bonuses came out too. They had to have that diagnosis in order to get the 20% bonus for COVID patients. So any patient that was admitted that had a COVID diagnosis, they got a 20% bonus for that. If they were put on remdesivir, that was a new technology, and new tech codes can apply for an additional 20% bonus in payment because of the risk of an unproven technology. So remdesivir, Gilead had actually applied for a new tech bonus payment for remdesivir. So the new code was created for remdesivir in April, and that's actually what launched the hospital protocols, because people were actually doing well when they were treating them with hydrochloroquine, which came from Operation Warp Speed, actually, and the national stockpile of hydroxychloroquine. Hospitals got a free donation of that, like right at the end of March. And then 3 days later, a few days later, April 1st, the new diagnosis came out, the bonus for remdesivir came out, and it was like a line in the sand. We stopped azithromycin and hydroxychloroquine, and we went straight to remdesivir where we got the bonus. And then of course we got a 20% bonus for putting patients on a ventilator also. And so also the other part of that was the PCR tests. So I noticed that I actually worked in a hospital university lab for a long time. My mom was a medical technologist. That was her profession my whole life. And I had actually run at one point the rapid, they used to call it a rapid flu test way back in like 2004 when I was working in a lab. And that was the prototype for the COVID-19 PCR test. It's basically a PCR test, but it's not quite the same methodology of how you do the cycle threshold thing. So when the COVID-19 test came out, there was a whole thing that happened with that too. And that sort of came with bonuses and incentives also that were not super easy to see on the surface. But what happened was the CARES Act provided money for all the COVID-19 PCR testing. So normally testing costs hospitals money, and so they don't like to do a whole lot of diagnostic testing to identify a virus or do cultures or anything necessarily. They actually start treatment before they know what pathogen they're dealing with, and then they may do identification later after they start an antibiotic or whatever, preliminary treatment they're gonna do. And initially with PCR tests, I don't know if you remember, but they had like tents set out where people could go and get PCR testing, but you had to have symptoms at that time. You couldn't just, they were saying there was like a shortage of testing. And it took, I don't know, maybe a month or so until they started screening everybody. Well, when they went from you had to have symptoms to get the PCR test, there was hardly any patients that had it. And then when they switched to now it's readily available, the CDC says that every hospital can do their own testing. And so we brought it in-house, and hospitals didn't have to send it to a different lab and wait a week to get the results back. Then we could do it all the time. So then 80% of our patient population became COVID positive, whether they had symptoms or not. And that had never happened before, that we had never used that test as a screen before. It had always been like a confirmatory test, like you had to have symptoms and the doctor had to not know which kind of disease they were dealing with, and then they do some sort of test to figure out why aren't you getting better with the treatment. So that policy completely changed, and there was a bonus to getting the COVID patients. So that's ultimately.
We had people telling us they'd go in for, I don't know, a broken leg or something completely different, and then they would be,
100%.
before they knew it, on a COVID ward because
Yeah.
they would. And then we had a nurse telling us also.
Yeah, because they would screen patients in the hospital for COVID. They would come in for a gallbladder removal or broken leg or a motorcycle accident or car accident or anything else. And while they were in the hospital, they would do this screen. And if they came up COVID-19 positive, that's when they would start the treatment. And they would put them on the ventilator fairly soon. They would start the remdesivir, and then they would have kidney failure and pulmonary edema, and they would just circle the drain. And it was like nothing that the hospital could do would save them. I've never seen anything like that. That is not how a normal flu case would progress, and that's not how a normal pneumonia case would progress. Before 2020, if patients came into the hospital with the flu or with pneumonia, they would tend to get better within 3 days and go home. Hardly ever would we have an inpatient admission for flu. Pneumonia, yes. Flu, almost never. And if they did, I mean, they were elderly and they had a lot of other things like organ failure or heart failure or cancer going on, and flu was just the last thing that was going on after a bunch of other things. It wasn't just flu, but for COVID, at first it was elderly patients, and then that I noticed that had symptoms, and then it started to get to be younger and younger people that actually had symptoms, because I wasn't even paying attention anymore to if they were COVID positive or not. I was paying attention to, did this patient come into the hospital with symptoms? Did they have some sort of cold or flu type thing or pneumonia type thing going on before they came into the hospital? Because at some point, the hospital sent out, like we have, whether you work on site or whether you work remote in almost any hospital, they have some sort of like an intranet for for employees, and it's like your very own home page that everyone sees when you log in every time you go to the computer. So that's where they put the messaging. The leaders put the messaging. So that's where like our case chart would be, how many COVID cases we had. At one point they sent out a message that said the FiO2 settings on the ventilators had been killing people, and we don't know how to treat COVID, so we were trying these ventilator settings thinking that that was how we were going to treat COVID, but apparently the FiO2 setting was actually killing people on the vents. So we're going to stop doing that. We learned that that was not working, and so we're going to adjust it, and we're sorry. And I was shocked by that, because I had already started to hear rumors that patients were being killed on ventilators in the hospital, which made sense to me because we had never had a flu case or a pneumonia case where someone's on a vent for a month and we can't save them. That had never happened before. Usually maybe 24 to 48 hours, and they're talking let's pull the plug, or get them out of the hospital and get them into some long-term nursing care setting.
Okay, let's go back a little bit. I want to go back to the PCR test. We had a nurse on this bus telling us that a patient would come in and they would be told from above, whoever that above person is, to keep testing until they got a positive.
Yeah, they did that. It was like they were playing roulette. And the doctors would even put in the documentation, I don't understand this. It's like the patient doesn't have anything I can treat. I keep doing the PCR test. It keeps coming up positive, and they have nothing wrong, and that would happen. They would do like 6, 7, 8 tests, and it would be positive, but the patient would have nothing wrong with them, and the doctor would be really confused. Sometimes they would do 4 or 5 tests, and they would get a bunch of negatives, and then they would get 1 positive, and they would take the positive and then treat the patient for COVID. So it was like playing roulette. They would just, even the different doctors were documenting, I'm not sure I trust this test, so let's just run it again and see what I get this time.
Now let's talk about remdesivir. Talk me through once more how we came to be prescribing an emergency use authorization thing for people with COVID that shuts down their organs, which is what we've been hearing over and over again.
It was really interesting. I don't know how it came to be approved. I wasn't privy to that. I looked it up later. But when the new diagnosis code came out, and also the code for remdesivir, which created the 20% bonus for it, we started prescribing it. And the hospital had a protocol about remdesivir. They knew that it caused kidney damage. It said right up front it causes kidney damage. But the thing is, all the propaganda, and I call it propaganda intentionally, was saying COVID-19 also causes kidney failure. And in the hospital, kidney failure is a very common thing. We call it AKI, or acute kidney injury. And so that was something that we saw every day. It was normal, a normal thing that we would treat. So it would be normal for us to see that and think, well, we're just dealing with kidney failure. It's just something that happens to people sometimes. And especially when they started programming us with, well, COVID causes kidney failure. But remdesivir also caused kidney failure. And they had to do an infectious disease consult and a renal consult before a patient could go on remdesivir. And if they had chronic kidney disease stage 3 or higher, they would be disqualified from receiving remdesivir. And we had to document like a permission slip and an informed consent form and put that all in their medical record. And then they would administer the remdesivir, and sometimes there was 1 dose, sometimes there was a few doses, but they all ended up with kidney failure within a few days. Some patients ended up going home with home dialysis prescriptions. Some patients ended up on a kidney transplant list. Some patients ended up with chronic kidney disease after they were given remdesivir, if they survived. And a lot of patients ended up with COVID pneumonia, which is apparently remdesivir causes the kidneys to shut down. And when the kidneys shut down, they regulate fluid levels. And when you can't get rid of fluid in the body, it builds up, and it comes up from the abdomen area, and then it goes through the diaphragm, and it can get into the lungs, which we were calling pleural effusions, or which we also, on an x-ray, it looks like what we would call pneumonia. So we called it COVID pneumonia. But if you look at the chest x-ray of a patient with pulmonary edema versus COVID pneumonia, they're almost identical. And providers, even though they knew remdesivir had this risk to the kidneys, they never connected that that might be causing patients to have kidney failure after they administered it. They just thought it was COVID.
But it's just the money. I mean, the minute they saw they got bonuses from the PCR tests and everything,
Yeah,
it was money. It was
Yeah.
the money. It changed. The whole thing changed.
the whole thing. Yeah.
Right, I have to ask you another question. So we've had hundreds of COVID protocol deaths situations, and you're sitting in the memorial right now, and you can see them all.
I know.
They were all unvaccinated. So the first, this is the thing we're trying to get to the bottom of. We have people that come in, and the first thing they're asked in hospital is, are you vaccinated or unvaccinated? In other words, did you take the COVID shot or did you not?
They weren't asking that in my hospital. It was almost impossible to figure out at first. It was like they didn't want us to know. They didn't, and I know from the medical coding thing, working with emergency room, that one of the things that we need to gather information on is if a patient was injured, where did that come from? There's actually a code for that. If there's a side effect of a vaccine, there's supposed to be a code for which vaccine the injury came from. And that's how they can look it up, like researchers can look it up as part of a study. If you know which code to look for, you can pull every medical record that has that particular symptom with that cause. And you can put a study together with that information. You can solicit the CDC or the WHO to get that data. That's the whole point of coding internationally, is to capture that data. But they weren't asking that on the front end at first. It was almost impossible for me to find out. I had to look into the notes. I had to go through literally 40, 50 pages sometimes of notes to find where the patient told the nurse or the doctor, I received the COVID vaccine.
So we're hearing something totally different. So let me go back to where we were, what people are saying. They're saying that they're going in, the first thing they're asked is if they've taken the COVID shot or not. If they have taken the COVID shot, they go one way. If they haven't taken the COVID shot, they go another way. And this is hundreds and hundreds of people saying the same thing in different states. So there's something going on. So the ones that are not vaccinated get taken straight into a COVID ward, remdesivir event, death. Very few got out of that. The vaccinated, some of them do get remdesivir, but they never seem to die. They get sent home, or maybe they die at home of something else, but they're not killed by the hospital protocols in hospital. That's what we've seen. And one nurse came and told us that when there was a death from the unvaccinated, there was no drop down to put in that this was an unvaccinated
I had heard that too,
vaccinated
and I had heard that that was in the EPIC system, and that's what I worked with. I actually worked in the EPIC system, like in the hospital, helping to develop that and figure out, you know, which kind of things do we want to prompt the doctor to put in the medical record. That was part of my job. So totally understand, and I had heard that nurse actually give that testimony, and I can totally believe that. However, I wonder when that switch happened, because I quit working for the hospital in April of 2021 over the vaccine mandates. I would not be vaccinated and I would not be PCR tested, and they were even starting to put propaganda in the hospital, messaging on the internet saying it's you that's the problem, you're working from home, you never see patients, but you're the one giving COVID to grandma, so you need to get vaccinated. And there's a Medicare incentive that they actually get money if they vaccinate their staff, and there's a massive amount of money they would lose out on if they didn't vaccinate their staff, so they were incentivized to say that. And I knew I wasn't going to be able to get an exemption, so I quit at that time. That was pretty early on. They might have switched it after that, because I feel like so the vaccine went out in January, or December 6th actually. December 6th, 2020 was when my hospital started giving out the vaccine through the drive-through. And then I quit in April 2021. So that was only a 4-month period. And during that time, they didn't have drop downs. They didn't have a questionnaire, because that's something that I would have had to look at in my everyday job, because I had to identify, is this patient COVID positive? Are they not? And I had to look at, every single record that I put that on. Our hospital wanted us to verify that.
So do you believe that the people are saying that their loved ones were killed in hospitals with the COVID protocol, and that should never have happened, obviously? Do you believe them?
100%. I knew they were killing people. I knew they were killing people in the hospital. I would cry myself to sleep at night. even thinking about giving my speech today, sorry, there was so much death. It was almost unbearable. Hospitals became the place where people go to die instead of the place where people go to get better. They separated newborns from their moms. They let people die alone without being able to say goodbye. They drugged them and they strapped them down, and people died without being able to say goodbye to their family. Some of them just got a phone call. Some of them didn't get anything. Some of them just weirdly died in the middle of the night when there was a skeleton crew on, and they had been doing fine up until that point. And then just all of a sudden, overnight, they crashed. I don't know what happened. And that had never happened before the COVID protocol rolled out in 2020. So yeah, when they say they killed people, I agree with them. And I told people from probably April on, don't go to the hospital. They're killing people in there. Stay away. I don't know what's wrong. I didn't know what was doing it. I honestly didn't know it was the vents. I didn't know it was the remdesivir until I looked into it later, and I was able to kind of connect all the dots. But I knew they were killing people.
What about vaccine injury? The ones that actually took the shots, what did you see there?
Massive. I didn't know it was possible for a human to die so horrifically and so quickly before they rolled out the mRNA injections. It was insane. I've never seen anything like that. The worst of them were the ones, they called it sepsis, but it was like instant multi-organ failure. Like within hours, patients would die of liver, lung, kidney, all at once failure, respiratory failure. It was like some of the records, the emergency crew that found them, it's like their body tried to reject everything, and some of these cases, like their family would be there 30 minutes before, and then within an hour they're dead. And then there were patients coming in with seizures like I've never seen before. We couldn't control some of them. Days patients would be seizing, and no medications would stop it, and eventually they kind of had to be put down. They called it encephalitis or encephalopathy, and then later on they even the coding information organization AHIMA admitted COVID-19 associated encephalitis. There were blood clots, strokes. The clots were insane. Never seen clots like that before. Even the interventional radiologists that were going in with, they have angiopathies and, different scopes where they can do like heart interventions and put stents in like a carotid artery if you have a stroke going to your brain. Normally it's rare to have more than one stent go in. And they were documenting, multiple locations all at once. They had heart attack cases that were like that, where they needed massive amounts of stents that they never needed before. There were people in their 20s that had been hiking that were totally healthy, had been running marathons, that suddenly needed a leg amputated because they had a massive blood clot going from their hip all the way down to their leg, and it couldn't be saved. So that happened. There were some cases of overnight spinal gangrene, which I've never seen before. And you can't amputate, the spine when it goes gangrenous. Normally they cut out tissue that's dying like that, so it prevents further infection. And they didn't know what to do. The only thing they could do was, basically replace that part of your spine with an implant. That's the best they could do. It was really intense. And I didn't question the vaccines as much as I should have. I started to about the flu shot way back in 2004. But with the pressure to get the COVID-19 shot, I started looking into what it could do, and I knew I didn't want anything to do with this experimental mRNA thing. And when I started looking into the experts that were saying, well, this is what this potential vaccine could do, this is what the research says, I was looking at the vaccine trials and what was happening to those patients, and the Guillain-Barré that was happening, and the strokes that were happening, and so I kind of knew to look for that when the vaccine came out. And the doctors were, baffled. They weren't connecting the dots. But to me, knowing what the potential causes or potential symptoms of a vaccine injury could be, we 100% had all of the things that I just described. But doctors would never tell you that. They would just say it's a stroke, it's a heart attack, it's a blood clot, and they would never connect the two.
Is there anything that would make you take a vaccination of any kind ever again?
They would have to kill me. Nothing would make me take it. Not any more kinds. No more vaccines. Nope, I've never had COVID.
Or flu or whatever.
No, I had a cold once in 4 years. I call it a cold because it felt just like a cold. I didn't have I lost my sense of smell. It felt just, I wasn't even really down that bad. I just, got the sniffles for a couple days. Really, it wasn't that bad. But I take zinc and vitamin C and glutathione every day, and I eat clean, try and take care of myself. So,
is there anything else you want to add to the story? Anything else you want to say?
I don't know.
Would you take someone you love into hospital?
No, not any. That's a really hard question, because I want to say 100% no, but there are some exceptions where, if you have a massive injury where your arm's broken, like a holistic doctor isn't going to be able to set it in the same way depending on what kind of a break it is. They might not be able to do the diagnostics, but them coming at me with a needle of any kind, I don't really trust it. I don't trust PCR tests. I'm not going to let a doctor try and diagnose me based on that. I would have to know the doctor or the care team, that hospital. I would have to vet them, and my dad's probably going to need care soon. So I'm working as best I can to try and keep him at home.
Are you employed again?
No, I have not worked in 3 years. I have tried not to go back into healthcare because I knew I wasn't going to get an exemption, and I'm kind of trying to go back into it now, and they're still requiring, it even says right in some of the job descriptions that COVID-19 is still going to be required, and there are very limited exemptions allowed, and then all the other vaccines are still required. So probably not a good chance that I would get a job in healthcare if that's part of it. I wanted to grow food and maybe work with animals like I did before I went into healthcare, but that's been really hard to get into. There's not a lot out there, and I'm a woman, so apparently I'm the wrong gender to start farming or working with animals or growing vegetables.
Well,
I don't know.
That for a start. Listen, thank you for being so brave. And is this the first time you've spoken publicly about this?
Yes.
Thank you for doing that. It's very important information you've given us. We truly appreciate it. Thank you.
Thanks.